So my clock says noon and we are going to get started. Welcome to the Vaccine and Your Workplace, which is being brought to you by the Baumhart Center as part of the Quinlan School of Business and the Parkinson School of Health Sciences and Public Health. I am just going to briefly walk you through our agenda. I am Seth Green, the founding director of the Baumhart Center, and we have a very exciting 4-part agenda for you in the hour ahead. We're going to hear a welcome from Dean Elaine Murato, who is at the Parkinson School. We are then going to hear about ensuring effective and equitable distribution of the vaccine from Colleen Clark and Jerry Krishnan, who are at UIC and who are also part of the Vaccine Core Partnership. And then we're going to look at employer case studies, and that should say employer case studies. I notice these mistakes only when they're up on the screen, and that will be with our own Nadia Sawicki from Loyola. And so we're going to come very quickly by about 12:35 to 12:40 to your questions. And as you're already doing, we will look forward to seeing your thoughts in the chat around what you'd like to learn from our phenomenal guests. So let me start by turning this over to Dean Elaine Murato, who is going to give us a strategic overview and set the stage. There has been a lot happening in the world of COVID and vaccines, and she's going to provide that context before we jump into the discussion at hand today. Yep. Dean Murato?
Thank you very much. You can forward. There has been a lot that's been accomplished, and I think it's always good to ground ourselves in the positive of what has been accomplished. When we last convened our group, it was late in December, and we were anticipating having vaccines on the horizon, and now we can be talking about they're here and how we implement. And it really does reflect an unprecedented scientific achievement that we have 2 vaccines developed that are highly effective and safe, authorized and begun distribution in less than 10 months. For those of us that have been involved in drug development or vaccine development, this is quite exceptional. And we have 2 more vaccines on the immediate horizon. We'll be seeing some of their results, it looks like later this month or early next. And so the country has been very focused on bringing together the right people at the table around Operation Warp Speed to help make this happen. Next, please. But it's not just about having the vaccine. It's, are we confident that we have a vaccine that we're willing to take? And I wanted to take a moment here. This here is a quote from the FDA Commissioner, Dr. Stephen Hahn, at the time in which the second vaccine by Moderna had been approved. And it's important to note, it has been open and transparent. Myself, as well as Dr. Krishnan, have served on FDA Advisory Committee. If you want to see the exact data that was reviewed by these committees, you can go to FDA's website, receive and see all of the data as synthesized by both the industry and the government, as well as what was the scientific review and comment. And it was that determination that came out to say it was safe and effective for emergency authorization. That meant it met standards necessary given the pandemic conditions. And it also means that there's going to be extensive post-marketing evaluation to continue to assess how it's being involved. So that's a very key part of what we're talking about today, is being part of that fabric and building out our safety net in terms of vaccine use. But I want everyone to know that from everything all science is seeing, that this was done in an appropriate way, and we should feel confident about the safety and efficacy about the vaccine. Next, please. Oops. So here we are. Operation Warp Speed is not just about developing, not just feeling confident about the data, it's making it that last mile. And that's what brings us here today. A lot of effort and work went in at the federal level to make sure it was manufactured, went through distribution and got to sites that it could be delivered. But here we are at the last mile, and how do we get it from those distribution sites into people's arms, whether that be through hospitals, pharmacies, employer settings, school settings, et cetera. And excited to have the folks here who are representing the Vaccine Core Partnership in Chicago to be able to talk more about that. And I think it also highlights what's been a key theme that we've tried to emphasize, Seth and I, that in order to do this really requires our ability to leverage existing networks, processes, and what we call cross-sectoral partnerships. Nothing better than this to highlight that. Next, please. So we'll be talking about that, but it's a race against time, and that's why implementation is so critical here. We've been hearing lots in the news. We've been living through it. It looks like maybe we're cresting perhaps in terms of cases, but still to see, unfortunately, more deaths and hospitalizations, which are lagging indicators. But that's been cresting. At the same time, we're starting to also hear news about emerging new variants. Viruses don't stand still. They are adapting as well to their environment. It looks like these strains that you hear emerging from the UK or Brazil or South Africa are mainly affecting the infectivity, how well they are latching on to humans and infecting us, not so much on the severity of illness. And the data to date doesn't look like it's affecting too terribly at all the effectiveness of the vaccines. But it's a race against time because, next slide, I think of this, a good way to conceptualize it is like a tug of war. We're building up our population's immunity, whether that is people unfortunately getting ill or by vaccine. At the same time, the virus is trying to battle with us and improve how it infects us. And if you were listening to the news shows this weekend, I pulled this quote from Dr. Scott Gottlieb, a former FDA commissioner, that we are potentially facing a perpetual infection of COVID in spring if these new variants do not spread and we are not successful in rapidly immunizing. So that's why today's topic is so critically vital to the health of those here in Chicago and beyond. Next. So Chicago is transitioning in various phases. I'm not going to go into this in detail because I know our speakers will be covering it. Just to highlight that this is where, how do we do the implementation in an equitable manner really plays out. Who falls in 1A, 1B, 1C, and phase 2? And how do we ensure that we're balancing the supply and the demand with the need and who's most at risk? Next, please. And that's why coming together as cross-sectoral partnerships in how we think about public health agencies, healthcare settings, school settings, and employer settings is so important as we think about the implementation here. Next, Seth. And recognizing that in some ways we're building this vaccination distribution infrastructure as we're flying the plane. Good news on the horizon is that with a change in the federal administration, we're seeing a reinvigorated federal response coming out of the president-elect, a commitment for 100 doses in the first 100 days. This was underscored and reiterated by the incoming proposed CDC director. And really, how do we double down on the operationalization of this and getting it not just from the science, but out into the field? We're starting to see some local state municipalities also organizing around this. Here was a recent press announcement coming out of Washington State and how the governor is announcing these sort of public-private partnerships, in this case involving Microsoft, Kaiser, and other entities within the state to make sure that it can be the best operational efficiency as possible. And so that's where we turn here next. With our speakers, and today is to explore, to better understand what are the steps, what's occurring right now in Chicago in real time, and how can we all be contributing to the implementation of the vaccines in our area, and with considerations of how do we do it equitably and how do we do it in a legal framework as well. So without further ado, I'm going to turn it over to Dr. Krishnan and Colleen Clark, who are going to walk us through the exciting stuff happening here in Chicago. Thank you.
Thank you so much for having us. And maybe I'll just let Dr. Krishnan and Hugh Music introduce themselves very quickly.
Sure. Good afternoon, or actually good morning, everybody, depending on where you are calling from. My name is Jerry Krishnan. I'm a practicing physician and also the Associate Vice Chancellor at the University of Illinois at Chicago.
Is Hugh Music muted?
You may be muted, Hugh, but that's okay. You may not be unmuted. Seth has a lot of power apparently on these calls. Hugh is co-director with me and directs the Population Health Sciences program and is part of the brains behind this operation.
And he was unmuted if he wants to introduce himself directly.
Jerry did a great job. Thank you.
Perfect. Go for it, Colleen.
All right, great. Well, thank you so much for having us today. We're really looking forward to this discussion because, as the dean said, this is super timely topic. It's everywhere. It's what I think a lot of us are thinking about in our personal and professional lives. So I'm a senior design strategist at the Institute for Healthcare Delivery Design, which sits in the Population Health Sciences at UIC and directed by Dr. Krishnan and Hugh Music. So next slide, please. So just a quick overview of what we hope to touch on today. And again, per your questions, we can share more information, but kind of speak to a little bit of the origins of the Vaccine Corps partnership, which is a massive collaboration that's happening locally to address this concern around equitable distribution of vaccine. Then share just some really high level initial findings from an information needs assessment that Population Health Sciences funded and conducted. And then kind of taking a look at what design strategies and designers can do in terms of the space of vaccine distribution. And then considering some calls to action for business leaders in the community. Next slide. So I want to start off by saying a lot of this work that we're speaking to and sharing today is not just done by Dr. Krishnan and Hugh and myself. We're representing many collaborators across many sectors, and without them, we wouldn't have this work to share. So just want to give that caveat. So the Vaccine Corps partnership, I'll just start with the very quick origin story. It started with this program called Champions, which is a partnership between UI Health and Chicago Public Schools, and it's a program for high school students on a kind of earn and learn type of program where they work towards being pre-qualified for employment opportunities at UI Health, while also learning about the health sciences professions. And so normally this would be an in-person opportunity, but with the pandemic and so many other things, they had to pivot and go virtual. And so the program was such a success. Part of what they did was follow up, do phone consultations by being supervised by medical students, follow up with COVID-19 positive patients. They also had a community health project, and then they also participated in a speaker series where they learned about different pathways within the health sciences. And so overall, there was a lot of overwhelming report by the participants in terms of pre-post surveys about increasing their health knowledge, especially around COVID-19, and also increased motivation to pursue different health-related professions. And this program was generously supported by the Michael Reese Health Trust. Next slide. So what came out of Champions is that Hugh and Dr. Krishnan and then my colleague Jenny Snyderman, who's been leading the Champions program, presented how they creatively did this pivot. And so Dr. Krishnan and Hugh and Rachel Eichmann from the Michael Health Reese Trust had a little bit of a light bulb of, okay, we know a vaccine is coming. No one was talking about it back in early September, which I know feels like 2 decades ago, but we know that this thing is going to come at some point. I think it came way faster than any of us thought. Maybe Dr. Krishnan wasn't surprised, but I certainly was. So how do we get prepared? How do we get prepared to make sure that not only do we have this incredible innovation of science, but that people want to take it, they want to, that they trust it. And so that's where the origins of the Vaccine Corps partnership began, was how do we create a network of trusted messengers who then become this workforce who are tasked with accurate messaging and making sure people can access the vaccine. Next slide. So just high-level goals of the Vaccine Corps partnership. First is to define, identify, and mobilize trusted messengers that are within the communities and of the communities that are disproportionately impacted by COVID-19. Also making sure that we're co-creating with community members these messages and that they are culturally tailored and appropriate and also align with the values of those communities. Third, designing a long-term model for community-led development. So this is about creating a bi-directional channels of communication. It's not just a push of information. It's really about cultivating spaces for dialogue and relationships that can facilitate that. And then also coordinating logistics across institutions and aligning efforts around messaging, because this is a massive effort that requires so many of us. And then creating ways to kind of share out what we're learning in real time so that as we iterate, we can be learning as we're going and sharing best practices across the city. Next slide. So this is on the right, this is very, very early stage stakeholder map. Just goes to show when these conversations started, we had people joining each week. We meet Tuesdays actually at this time, normally at noon. And now we have well over 50 organizations, approximately 150 individuals, and we have fantastic coordination representatives from IDPH, CCDPH, and CDPH. Loyola University is also represented amongst this group. Some of you may be on the call. And we have over 100 participants at each meeting, and it's truly multi-sector collaboration. And because of Dr. Krishnan and Hugh's leadership and vision, this has now gotten to the point where Partners in Health, which for those of you who don't know, is a well-known organization that normally fights pandemics abroad, but because of what's been happening here in the States, they've been tasked to kind of helping the states and cities figure out how to do contact tracing, testing, and now vaccination. They have now come in and they're project managing and bringing their expertise on how to battle pandemics alongside communities and also do it in a way that's equitable. Next slide. So the whole vision around this Vaccine Corps partnership, that is not just about vaccination. It's about how do we create a sustainable workforce that also addresses economic needs and all the other issues that are coming alongside that existed before COVID-19, but are worsening because of COVID-19. So how can we really kind of work towards health equity, but also economic equity, and just build a stronger, more resilient city? Next slide. So to start answering some of these questions, we did an initial information needs assessment. So we sent a very short survey that had some open-ended questions and some closed-ended questions. And we partnered with Mile Square Health Center and then the Office of Community Engagement and Neighborhood Health Partnerships, also known as Ocean HP, and Illinois Unidos, all of which their leaders have been very active in the Vaccine Corps partnership from the beginning. Next slide. So this survey was asking questions, some basic demographic questions, but also things like, are you willing to get the COVID-19 vaccine? And so this survey was distributed about in the middle of December, early to mid-December. And so considering that was before the EUAs and before the vaccines are actually on the ground. So take that in mind when you're looking at this data. But also questions that included things like, what do you want to know to make an informed decision for yourself and for your family? What types of information do you want to know and who from? And so these are just some highlights. Approximately about 70% of respondents were willing to get the vaccine. Most of the respondents were under 65 years old, and majority were Hispanic or Latino or Black. And then the top 5 neighborhoods are listed below. And it was a real testament to our community-based partners that were able to get so many responses within under a week. I mean, it was really astounding. It just goes to show there's a lot of hunger for conversation around this. Next slide. So one of the questions we asked was, how has COVID-19 negatively impacted your life? And so the top concern was time with family and friends, which is not a surprise, but we want to highlight the fact that over 50%, especially those who were respondents who identified as Black or Latino, indicated a negative impact on their mental health. And so I think that was just something to pull out, especially for the business community, as you start to think about addressing some of these issues in the workplace. Next slide. So when we asked, okay, what type of information do you want to know? Some really high level common themes were things around safety and side effects, both short term and long term. We saw a lot of responses trying to get at, okay, what is it going to be like in a year? What do I need to worry about? What could happen to my body or how I could feel? Also around efficacy and protection from COVID-19. Can I still infect others? Can I still get sick if I get the vaccine? And then there's a lot of curiosity around, how are vaccines actually made? Who is making them and how do they work? How do we know they're effective? So a lot about the mechanics. And out of respondents who responded no, that at that time we're not willing to get the vaccine, almost 80% said they want to know more about safety and side effects. And then we also asked about, if your primary care provider, if you have one, recommended the vaccine, would you get it? And about 39% of those respondents who said no, if their primary care provider recommended it, they would say yes. Next slide. So again, we also asked about what type of information you want to know, but then who do you want to know it from? And the most common response was from my healthcare provider. So there's actually a fair amount of trust in your healthcare provider. And now also a lot of this, I don't think will be a surprise, but a lot of talking about the internet, whatever the internet could encompass, that's maybe in another iteration. We'll kind of tease out what that could be. Social media, it could be, discussion boards, who knows? And then of course, Dr. Fauci was also mentioned quite frequently. Next slide. So what is the potential role of design? So I'm design strategist talking to you about vaccine distribution, maybe a little bit unexpected, but there's a lot of role for design methods and designers to play in this space. Next slide. So this is Buchanan's 4 orders of design. And so just really quickly, design is an emerging, evolving field. It really encompasses things from visual communication and objects such as product design, things like your phone, interactions and experiences. A lot of you may have heard of UX design, and things like services and entire systems. So it really ranges from something tangible and visible, something we can see and touch, to really abstract and invisible. Next slide. So just some quick examples of how this would map onto the current context. So things like if you're sending your employees to go get the vaccine, wherever that may be, do they know where to go? Is it clear signage? Is it accessible in multiple languages? Is it clear? Is it visual? Things like informed consent forms, you're going to get a lot of information about potential side effects. Is it easy to understand, for people with different degrees of health literacy? We hear a lot about, do I know when it's my turn? Do I know how to sign up? Do I do it online? What if I don't have access to online? Is there a phone number? And so we're getting from the first dose, if they're getting the Pfizer or Moderna, to the second dose, is that experience from end to end seamless? And if I have questions, or if I have a concern about side effects, is it clear who I can contact? And then are systems such as public health departments, health systems, employers working alongside each other, not duplicating efforts, which is clearly what the Vaccine Core Partnership is striving to do. Next slide. So just some real quick considerations, questions I think come up from this work, and we look forward to hearing more from you all what you think about this. Next slide. So find out from your employees what they want to know. No group is the same. There's a lot of common overlapping concerns around the vaccine, but then there are a lot of differences based on population segmentation and what group you're in. Thinking about different ways of communicating. So not only what do people want to know, but how do they want to know it and from whom? Making information accessible and tailored, so including visuals. That's my bias as a designer. I like to think and work visually, but also verbally, different languages, and also mode. Is it online? Is it a phone conversation, etc.? Is it a chatbot? And also to consider collaborations and partnerships to accomplish 1 through 3, and then also leading on the Vaccine Core Partnership, because there's so many people and amazing groups working together in that space, and we'd be happy to share information offline with you about it. Next slide. So last but not least, and this is a image that Dr. Krishnan came up with, but that vaccination is not the only part. We have to remember, I think it's so easy to think, things are so dire, the vaccine's going to be the silver bullet, that's it. None of it will matter if we don't have trust, if we're not doing things in collaboration, if we're not also taking all these other measures into account, such as social distancing, washing hands, but then also paying attention to social determinants of health. Those are just as important. Next slide. So we look forward to your questions, and I hope that some of this was helpful, and thank you for your interest.
Thank you so much, Colleen. That was both a sobering presentation in reminding us of how many things we need to be doing to move the needle, but also an enlightening one in the sense that look at all of the organizations that are coming together to begin really getting this off to an equitable footing. And so we've talked now about how to think about how Illinois can come together and move forward all of those different pieces on the social determinants. We know that many of you are leaders of workplaces. And so we know you are also thinking about how in my business or nonprofit can I play a role in being a partner and an agent in a positive way? And Nadia Sawicki is a professor at Loyola. She is also the co-director of the Beasley Institute for Health, Law, and Policy. And she looks at a lot of these issues from a legal lens. And so we wanted to invite her to share her thoughts on the role of the employer as the vaccine becomes possible and as you all think about what this means for your policies and protocols. And so, Nadia, let me hand it over to you.
All right, thank you so much for having me, Seth and Dean Morato, and thank you, Colleen, in particular, for that fantastic introduction to the on-the-ground work that's being done surrounding the COVID vaccine. I have been invited to speak with you about some of the legal implications of the vaccine, and in particular, a question that I know many of you have asked about, whether an employer can mandate that its employees be vaccinated. I do need to preface this by saying that the views I express are my own and not those of Loyola University Chicago, and that I am not offering legal advice. But here are the three big picture takeaways that I'd like you all to focus on, and I'll be walking through each of them one by one. So first, the EEOC, the Equal Employment Opportunity Commission, and courts have repeatedly concluded that employers can mandate FDA-approved vaccines for their employees subject to the limitations of the Americans with Disabilities Act and the Civil Rights Act. The uncertainty that we are facing today is whether this position extends to the COVID vaccine, which was approved by the FDA under the emergency use authorization process rather than the traditional drug approval process. And this is an issue of first impression, which means that neither the EEOC nor courts have explicitly given us a yes or no answer on this, but preliminary guidance suggests that there is no legal prohibition on doing so. So at the end of the day, and this may not be kind of a satisfactory recommendation, but at the end of the day, your decision as employers as to whether to mandate the vaccine is going to come down to a decision about how much risk you're willing to accept. And this is primarily, I would argue, a question of business risk rather than legal risk. The survival of your business comes down to whether you're going to be able to hold on to your employees if you impose a mandate, how your customers and clients will respond if you don't, more so than any risk of legal action or litigation. And this may sound strange coming from a law professor, but I do think it is a more realistic perspective. Next slide, please. So first, the position of the EEOC and courts on employer mandates of FDA-approved vaccines. So the EEOC, as you know, enforces the ADA, the Civil Rights Act, the Age Discrimination in Employment Act, the Genetic Information Non-Discrimination Act, and other laws that protect employee rights. During the 2009 H1N1 pandemic, the EEOC took the position that employees could mandate an FDA-approved vaccine for the flu, provided that employers complied with the conditions of the ADA, which speaks to medical exemptions, and the Civil Rights Act, which speaks to religious exemptions. So under these statutes, there are two major conditions that employers need to comply with, and these are much more nuanced than I'm explaining here, but unfortunately we only have a few minutes. So first, it is essential that the employer articulate a job-related reason for the vaccine mandate. Under the ADA, for example, a mandate would have to be job-related and consistent with business necessity, and that includes protecting employees against direct threats to health or safety. Under both the ADA and the Civil Rights Acts, employers have to offer reasonable accommodations, for example, remote work, masking, etc., to employees who seek an exemption, unless that accommodation would cause an undue hardship to the employer. And how undue hardship is assessed really varies for these two statutes, but I'm not going to get into the details now. Next slide, please. So let's talk about how this applies to the COVID vaccine, which is approved by the FDA under an EUA. Right, so an FDA emergency use authorization gives the FDA the authority to allow the use of unapproved medical products in an emergency to diagnose, treat, or prevent serious or life-threatening diseases when there are no adequate, approved, or available alternatives. In layman's terms, this means that a vaccine approved under an EUA hasn't gone through all the steps needed for FDA approval, although as Dean Morato said, it has been pretty rigorously tested. It just hasn't gone through that last step. One important thing to know that you may not be aware of is that EUAs are in effect only for as long as the public health emergency lasts and can be revoked at any time. So if the pandemic abates, for example, FDA approval for the use of the vaccine might be withdrawn. So Does the COVID vaccines EUA status change the EEOC's position on employer vaccine mandates? As I said before, we don't know with 100% certainty. Attorneys are by their nature very risk averse, and they won't tell you you can do this unless they have absolute confirmation from each and every federal and state actor involved. But here's what we do know. First, the EEOC has confirmed that COVID-19 is a direct threat under the Americans with Disabilities Act, and that you can act to protect against those threats. It has explicitly said that the ADA, the Civil Rights Act, and the Age Discrimination Act do not prevent employers from following the guidance of the CDC and state public health authorities about the steps that employers can take regarding COVID. And the EEOC has previously acknowledged that employers have very broad authority to take protective measures against COVID, including administering COVID tests to employees, asking about symptoms of COVID, COVID diagnosis, asking about contact with people with COVID, asking about travel, requiring a temperature check. Again, all of this is subject to the limitations of the ADA, the Civil Rights Act, and confidentiality laws. Next slide, please. Most importantly, on December 16th, just a few days after the first EUA was granted, the EEOC issued comprehensive guidance where it discussed the possibility of employers requiring vaccinations, quote, when they are available, and how employers should respond to requests by employees for accommodations. Now, this guidance did not specify anything about what availability means and how that relates to the approval process, but the fact that the EEOC is contemplating this possibility suggests that the legal risk is limited. In terms of other federal agencies, the CDC on December 31st issued guidance to employers in which it said nothing specifically about vaccines. On the FDA side, the FDA secretary has the authority to limit the use of an EUA product, for example, to disallow employer mandates, but it hasn't done so. On the other hand, the same day that the EEOC issued its guidance, the Surgeon General said, right now, we are not recommending that anyone mandate a vaccine. But again, there doesn't seem to be any explicit, clear prohibition. Next slide, please. So where does that leave us? If an employer chooses to mandate the COVID vaccine, but complies with the requirements for medical and religious exemptions and confidentiality provisions, I can't say there's no legal risk, but at this point, the risk seems limited. Even if an employer were to mandate a vaccine, the employee had some adverse injury as a result of the vaccine, a new law called the PrEP Act would likely limit any liability on the part of the employer. What about if you don't mandate vaccines? Is there a legal risk there? And we know that businesses have both statutory and common law duties to both employers and customers to maintain a safe environment. And failing to do so can expose employers to liability. For example, OSHA says that employers have a duty to maintain a safe workplace and that this requires adopting an infectious disease response and preparedness plan. So if a business doesn't require its employees to be vaccinated, but engages in other reasonable measures to protect employees and clients from COVID, like requiring PPE, social distancing, following other public health recommendations, there seems to be minimal risk of liability. And there are a number of reasons for this, but what it really comes down to is the question of whether not requiring a vaccine is unreasonable in light of current circumstances. And given that public health agencies like the CDC haven't recommended employer vaccine mandates, and that few businesses currently impose mandates, that would be a hard case to make. So the takeaway here, again, is not that there's no legal risk, but that the chances of getting sued and that shutting your business down are much less significant than the other risks you face as a business owner. Businesses need to serve their clients and customers effectively. Are your clients going to be comfortable if you take protective measures but don't require vaccination? And this is going to depend on context, depend on your business. A hospital may approach this differently from an accounting firm. Businesses need to foster goodwill among their employees and show their employees that they care about their best interests. What's the best way to do this? Given the evidence that we've seen about hesitance to take the vaccine, are you going to lose valuable employees if you impose a mandate? might it be more effective to provide information, encouragement, and resources, as Colleen was talking about, to your employees, rather than asking them to decide between a vaccine and a paycheck? On the other hand, allowing employees not to be vaccinated means you have to take other measures to mitigate risks. When your employees need to take time off to isolate and quarantine, that imposes costs on your business in terms of workflow and staffing. Now, it's true that many employers think that mandating a vaccine for employees is the correct business decision. A recent survey of 150 CEOs of America's biggest companies, 71% of those CEOs supported employee vaccine mandates, but recognized that this would be controversial. And I will note, as I'm sure many of you are thinking, while a high-profile Silicon Valley CEO may feel confident that they can stay in business regardless of how they approach the pandemic, a small business owner may feel very differently. As I said, at the end of the day, this is a business decision. You want to stay in business, you want to serve your clients effectively while maintaining a strong workforce. And right now, absent other information from the CDC, from the EEOC, from courts, I would suggest that how you go about doing that is much more dependent on practical considerations, HR considerations, and market considerations than anything else. Thank you very much.
Thank you so much, Nadia, and thank you to an amazing panel. We are now going to move into our power round of questions, and I'm actually going to stop sharing my screen so that we can see our 5 panelists on everyone's screen. And we're going to come first to a question from Kendra Fogarty. Kendra, can you introduce yourself and then ask away?
Sure. I'm Kendra Fogarty. I'm with US Cellular, based here in Chicago. We have around 5,500 employees across the country. My role in the company, I'm housed in the HR department, but I focus on corporate social responsibility more broadly. And my question for the panel is, I'm curious, with an employee base this large, there will obviously be employees who, mandate or not, will be unable to receive the vaccine, whether they have immunity issues or underlying issues that make them at greater risk for complications. How should employers be thinking about how we can still protect those employees who can't take a vaccine, mandate or no mandate?
Well,
We'll go to Nadia and then Jerry.
Sure, I'll speak briefly to this. You know, as of right now, employers are taking significant steps to protect all their employees from COVID. Masking, social distancing, potting their employees. One of my best friends is a restaurant owner, and I have sort of kept track of how she has managed her employee workforce throughout this. And so many of those measures that are still in place can and should still be used if you have a significant portion of your employee base that is not able to be vaccinated or chooses not to be vaccinated. So there's a lot of flexibility in how you do that. But I guess that Colleen and others may have some other thoughts about kind of managing that risk on a more practical level.
Colleen, you want to go first?
Oh no, all you, doctor.
Well, I mean, I think there's a couple of things going on here that probably worth saying out loud. What we know is that the vaccines have an incredible efficacy in terms of preventing what we call symptomatic disease. So what that means is that it helps prevent the number of people who feel sick and are infected. We don't actually know right now about the efficacy of these vaccines in preventing infection. And we certainly don't know about the efficacy of these vaccines in preventing transmission. And that may sound unimportant, but fundamentally what that means is that we don't know actually right now how effective these vaccines are in preventing me from getting infected, but being asymptomatic, meaning that I am infected. If you do a PCR test on me, it'll come back positive, but I'm not sick. And as you can imagine, if I'm infected but not sick, I'm actually at pretty high risk potentially of transmitting that and giving it to other people in the workplace. We also have no idea about whether it prevents transmission from one person to the other. What the data that we do have from the Moderna vaccine, and it's based on a subset of the 30,000 people that were enrolled, so not ready for prime time, is that it seems to reduce the proportion of people who get infected by about a third. So not by 95%, but by a third. So it doesn't seem to prevent infection. What it does seem to do is to prevent symptomatic infection.
Yeah.
So for that reason, the Centers for Disease Control and all healthcare practitioners, would basically say, even if you're vaccinated, you need to wear a mask, you need to remain physically distanced, you need to practice all the other public health recommendations that are in play. And until we know more, and we will know more in the coming months, because there's an enormous amount of data being collected about what's happening with transmission, what's happening with asymptomatic infection. Until we know more, I think I wouldn't treat your workplace employees that are vaccinated any differently than I would treat employees who are not vaccinated, because I don't actually know how dangerous they are, even if they're vaccinated. So
Right.
I'm right now vaccinated. I've received both my doses. I still have to wear a mask when I'm around colleagues at UI Health. I still stay physically distant because I could still be dangerous to them. So in summary, what I'm saying is we are at a kind of an interesting point in time where we have what seems to be an incredibly efficacious vaccine in preventing people getting sick who are infected, but the data are not yet out about how it affects infection and transmission rates. And I think we're a little too early in making, I would say, aggressive policies about what to do with individuals who are not vaccinated. At this point, I would treat everybody the same. They need to stay masked, distanced, and giving them the opportunity to get vaccinated, however you can.
Thank you. That was great context.
And if I could just, I'd just like to add to that. So for some of you doing some planning and thinking ahead purposes, if we look at how long will it take to get, let's say, everybody vaccinated, you're looking at summer, late summer, right? So we're in this, sort of period of time, as Dr. Krishnan is saying, that's about maybe 6-9 months. And so what we're hearing is to stay the course during that period of time while we get everyone up. And also at the same time, we'll have more information, or as you're saying, around the safety and that. That's going to be hard to do communication wise, right? And I think that's where the design thinking and messaging people, that wherever you might be, are going to be critical to that, because you're going to have a mixed population of people at various stages. And keeping everyone together on the ship together is an organizational HR challenge for sure.
Christina Paxson, you have our next question.
Hi, I'm Christina, and I'm a public health student at Loyola. And my question is, where do universities fall in the vaccine distribution? Obviously, students on campus are a huge risk within their dorms and spreading it around the community, but what about students that aren't currently on campus like most of Loyola? Where do both of these groups fall? And thank you guys, this presentation has been really helpful.
So Elaine, do you want to go first? And I can talk about UI Health.
Yeah. All right. So each institution will make its own call. And so one thing that we're looking at within Loyola is that's just like I would imagine University of Illinois Chicago or others that have healthcare as part of the educational experience. So they might be on a campus in which healthcare delivery is occurring. We might have students who themselves are part of healthcare delivery, for instance, helping with COVID testing and so forth. They fall in that category of 1A. That's the first group. So we do have within Loyola, as you have at other universities, a category of folks that are already being vaccinated right now. In the case of Loyola, this is being managed, since it was a specific question, being managed through our Loyola University Health System. That is the group, that is the one that has the ability by the government to actually be delivering the vaccines. And they're working closely with senior leadership at Loyola to coordinate that. Then the rest of us become the other categories that spread out depending on your age, depending on your risk level, and so forth. And I'll turn it over to Dr. Krishnan, who can kind of expand how that all waves out.
Yeah, I'm actually going to do a tag team and have Hugh Music maybe chime in.
All right, go Hugh.
Hugh, it's up to you.
Sure. So it's very much in line with what Loyola is doing. And I think it's been a great challenge in how to think about campuses as a whole, with them being self-contained with people on campus, and in particular UIC being a very porous, open campus with people being at home and coming and going. And so I think a lot of this is being governed by how we keep people safe. And, for the time being, that's having people continue to attend classes online. And in general, because students will fall into the later tiers, continuing with that for the foreseeable future.
Great. Our next question comes from Julie Bradigam. Julie?
Hi there, I'm Julie Bradigam. I lead Hollister Incorporated, a local medical device company's environment, health, and safety program. And I have a two-part question. One is around, if companies mandate or strongly promote the vaccines for their employees, but they might have a different approach for visitors or contractors that are required to come to the site. What liability does that open companies to, or should we have a consistent and unified approach on that? And the second question, if I may, is just around, do you see distribution channels opening up for private employers to offer on-site vaccinations versus relying on government vaccination programs? Thank you.
I can speak to the first part of the question. That is a challenging question. I don't have a clear or perfect answer for you. But again, as Dr. Krishnan was talking about earlier, even when vaccinations are in place, there are a significant number of protective measures that employers are still going to be required to take with respect to their employees. And treating visitors in the same way would be appropriate. Obviously, if you have visitors or some subcontractors, the employment the employment laws that protect against employment discrimination, et cetera, aren't necessarily going to apply to those individuals. But I would stress, as I think my co-panelists would, that to the extent that you can have uniformity as much as possible in terms of the policies that you're imposing on folks who are accessing your workplace, the better off you're going to be, and the easier it's going to be to implement.
Yeah, thank you, Nadia. And I would agree 100%. I think keep this simple. This is complicated enough as it is, and to have different requirements for different groups just adds an enormous amount of complexity. And maybe you could view this as a way that you're doing your part in promoting public health by encouraging as much vaccination as people are willing. At UI Health, by the way, even though I'm a frontline healthcare provider, I'm not required to get vaccinated. It's actually optional. Most of us are as physicians, but what we've noticed is that depending on the type of healthcare provider you have and the role in the healthcare system, there's varying levels of uptake. And we're trying to understand the vaccine hesitancy, even among healthcare providers. What are the different reasons for hesitancy, and using some of the data that Colleen has is helping us to inform how might we be proactive about communication? How do we message around risk? And there's risk both ways. It's not only the risk of the vaccine, but there's also a risk of you getting infected and getting very sick. And so I think messaging needs to talk about both sides of the fork, and letting people make some decisions. The reason we haven't required it at UI Health, again, as frontline healthcare workers, is because it's an emergency use authorization. I think there are a number of unknowns at this point. Certainly many of folks who are in critical care or emergency medicine, we're choosing the route of taking the vaccine because that seems a much surer path than to roll the dice and see what happens. But I think everyone's got a different level of risk, perception and risk mitigation strategy. And I think right now, informing and encouraging and referring people, is the way to go. So you're looking like you're part of, protecting everyone as best as you can, offering them advice and masks and so forth. The other question that was asked very briefly is about really moving outside of the four walls of healthcare delivery systems and potentially government-led, entities, such as right now, I think Chicago Department of Public Health is having mass vaccination campaigns within the city colleges, for example, directed at healthcare workers, but eventually they'll become available to the full public. From our standpoint, we have been in a number of discussions at various levels, including recently with the CDC director, who visited us last week virtually, kind of laying out even more aggressive strategies where workplaces can become actually vaccine clinics. So how might you be seen as offering employer health services that I think many of you do anyway? How might you offer convenience, but in a way that's not coercive? You're essentially offering convenience in a way to protect the workplace and letting individuals make that decision. We're not quite there yet, but I think this is the time to plan. And this is exactly the reason the Vaccine Corps partnership came into being, is to start thinking 1 or 2 steps ahead. So that as that step then comes, becomes current, you at least have had a chance to learn off of other people's learning curves, and you're a little bit better prepared.
Yeah, and I think those other alternative sites will have more options if we see good data coming in from the 2 vaccines I mentioned that are in the pipeline, one by J&J, for instance, and the other by AstraZeneca, are designed that's a little easier for storage, a little less what we might say fragile in that distribution channel, and therefore more amenable or easier to use in a broader range of settings. And so if that data is encouraging as we anticipate, that being ready for that eventuality. I'm sure many of you are seeing in the news giant parking lots and sports stadiums and all of that being readied for large campaigns in that way. So I think trying to have multiple sites where people have options, at least in the near term.
Joni Clunan, you have our next question.
Thank you, Seth. Thank you all for this fantastic seminar. The information has been invaluable. My question, it's actually 2 parts in terms of operationalizing a mandate. My first question has to do with, since vaccinations are phased, would you recommend then phasing return to work for employees based on a similar phasing? Certain people are getting the vaccines first, so would they be the first to return to work? And then for companies or organizations that have international branches, how would you apply or implement a vaccine mandate for international colleagues?
Spoken like a leader at the MacArthur Foundation, where you have people all around the world. Jerry, you look like you're ready to answer.
Well, I was just going to ask Nadia to answer, but I guess you've now put me on the spot here. Yeah, I mean, I think that you're asking a very important point, which is even at a workplace, you have groups at different risk of COVID, and so they fall in different phases. And some of you saw that Elaine had kind of laid out a very nice sort of figure that phase 1 of the frontline healthcare workers and folks living in long-term facilities. Phase 1B, depending on which guideline you're reading, is either 65 and older or 75 and older, and those who are what we call frontline essential workers. So these are people driving buses and trains and otherwise essentially are part of the infrastructure of this country, and they don't necessarily have the ability to protect themselves. Phase 1C is a much broader group, and for the most part involves almost everybody else, and then eventually you get to everybody. I would say most employers who they have in their workforce are sort of phase 1C or later. But you probably have members of your leadership. You may have individuals with certain comorbid conditions. So this gets a little bit, complicated as to how deep do you want to get into deciding who's in what phase within your organization. You get into issues of privacy and so forth. From our standpoint, I think, while it's important to think about having a mixed phase within your workplace, I think the thing to recognize is that even if you're vaccinated, you still need to practice all of the other public health measures. So certainly at this point, I think that the focus should be on encouraging your workplace to get vaccinated, maybe even doing some internal polling to understand, is there hesitancy? What are the kinds of information you need to be developing, and really engaging people in conversations. But at the end of the day, in short, I think if you have some of your individuals, employees vaccinated, others not, I would essentially treat them all the same with respect to their risk to other employees and I don't think you necessarily should say those who are vaccinated could come in and those who are not. I think everyone should be practicing safe standards as been recommended by the public health workforce. So long-winded answer to say more information coming, but at this point, promoting vaccination for everyone as soon as they can.
So go for it, Nadia.
With respect to your question, this is a non-answer, but with respect to your question about international employees, that's an issue that you really need to address to your legal counsel, because obviously different countries have very different expectations and requirements and limitations regarding employee health status, confidentiality, et cetera.
So I have one final question for everyone on this panel, and it's this. We have gotten off to a slow start as a country in actually getting the vaccine into arms. I believe the last time I looked that Illinois was a slow start state within a slow start country. I saw us as 37th in terms of percentage of population. And so I'm curious for all five of you, what are recommendations you might have for everyone here on how we can be helping to move that forward, since it's ultimately in the true greater good to see this needle move, pardon the pun. And Dean Morano, I'm going to put you on the spot first here, just to get us started, because I know you best.
Yes. Well, I have the tried and true public health answer. We are building this implementation system as we're trying to deliver. And it's rapidly evolving and changing. And every day in the news is going to be something new as to who might now be a next group available, depending on supply and so forth. So my advice is to stay informed and vigilant, and to go to trusted sources. So the local public health department, wherever you are posting on this right now. That's you can sign up for information to stay informed about your own local geographic area, as well as information more broadly about the vaccines that you can use and share. And I'll also note that there's already people that are trying to scam individuals with information around here you can sign up for and that. So we've got to be role modeling trusted sources and staying up to date. Thank you.
Thanks, Dean Morano.
I would just build on that. In the work that we've been doing together as the Vaccine Core Partnership, what we're really trying to lay out is a network of credible messengers. And as employers, you have remarkable influence because people come and work there, and their livelihoods are predicated on belief in your organizations to do well in the world and also to look after them. And that is an enormous lever to get more people on board.
Thank you, Hugh. Nadia, go. Jerry, perfect. Go for it.
No, I'm going to have Nadia go first. I'm going to switch the order here. Nadia.
All right, sure. From what I've heard from folks in the business community, the real challenge in terms of the decision of whether or not to vaccinate and how to, approach that in terms of the rollout is really employee resistance. And so I'd say that kind of looking at the evidence and the data that has been provided about the reasons for resistance to take the vaccine, introducing whether it's a community member or a healthcare provider. I know some businesses have kind of on-call COVID-specific healthcare providers to guide them on policy regarding COVID implementation, sort of finding out who those trusted sources are going to be and sharing that information in as clear and deliberate a way as possible with employees, so that they feel that they can make their own choices with full information.
Colleen, do you want to go next?
Sure. I mean, I would just not underestimate the power of creating those spaces for conversation, because there are FAQs out there. You can share those, but a lot of concerns are so deeply personal. And we do see some anecdotal data around just taking the time to have that space where people can discuss their concerns and validate them. That these are, it makes sense. This is unprecedented. I know that word is overused, and there's things that we know and there's things that we don't know, like Dr. Krishnan has said, in terms of if you're vaccinated, can you affect someone else, etc. So I just think putting all the cards on the table and creating that space can actually really move the needle more than I think we're anticipating. So if we do that more and more, I think we'll see more progress.
Jerry, you have our final word.
Thank you. First, thank you for allowing me to participate. I agree 100% with the rest of the panelists. I think if you haven't yet, start to begin conversations within your workplace about vaccines. Link your employees to trusted information sources. Maybe start beginning some listening sessions where you're having a conversation with individuals. Perhaps identify trusted ambassadors within your unit. They're not necessarily the organizational chain of command. There may be other functional chains of communication. So start planning for creating trusted messengers within your work unit as a way to prepare your work site for vaccinations when that becomes available.
Well, this has been an extraordinarily insightful panel. And the takeaway at the end is about how we have these conversations in our workplaces. And we are committed as the Parkinson School and the Baumhart Center to making sure that we continue this conversation with all of you so that you can continue it in your workplaces. And so look out for our invitation where the series will continue in February. For many of you who we didn't get to your questions, we promise to in the month ahead. And we look forward to being in partnership with all of you as we hopefully bend this curve and get to a place where all of us can have this discussion in person again. So until then, we look forward to being your partners in safety. And thank you to the incredible wisdom, Nadia, Colleen, Jerry, Elaine, and Hugh. It was an awesome panel. And I can see in the chat here, lots of gratitude. Have a good day, everyone. Bye.
Thank you.